Welcome. We'll continue with our discussion on secondary open-angle glaucoma, and in this session we'll be discussing about open-angle glaucomas secondary to disorders of the crystalline lens and open-angle glaucoma secondary to raised episcleral venous pressure. Glaucomas secondary to disorders of the crystalline lens can be either primarily open-angle or primarily angle closure in mechanism. And in this session we'll be discussing those lens-induced secondary glaucomas which are predominantly open angle in nature. The lens-induced angle closure glaucomas we'll be discussing along with other secondary angle closure glaucomas. Phacolytic glaucoma, also called lens protein glaucoma, occurs with a hypermature cataract when there is leakage of high molecular weight soluble lens proteins through microscopic openings in the intact anterior lens capsule. So in phacolytic glaucoma, the anterior lens capsule remains intact in contrast to the other two forms of lens-induced secondary open-angle glaucomas, lens particle glaucoma and phacoantigenic glaucoma. And with increasing age, the proportion of these high molecular weight proteins increase within the crystalline lens. These high molecular weight lens proteins and macrophages which phagocytose these proteins block the trabecular meshwork. So phacolytic glaucoma occurs in an elderly patient with a history of poor vision for a significant duration due to the hypermature cataract. And when phacolytic sets in this scenario, there is sudden onset of pain, redness and further decrease in vision. Clinically, we'll find an hypermature cataract and there can be wrinkling of the anterior capsule because of loss of volume of the lens. There will be prominent cell and flare reaction in the anterior chamber with large white particles in the anterior chamber, some of which are iridescent. The iridescent particles are said to be calcium and cholesterol crystals. These large white particles may settle in the inferior aspect of the anterior chamber and form a pseudo-hypopyon as seen here in this photograph. But no keratic precipitates are present, and this is a distinguishing feature of phacolytic glaucoma from phacoantigenic and lens particle glaucoma. Raised intraocular pressure with or without microcystic corneal edema is present. The anterior chamber angle will be found to be open on gonioscopy, but large white particles clogging the anterior chamber angle as seen here in this photograph are usually present. Treatment of phacolytic glaucoma is control of intraocular pressure as soon as possible, followed by cataract extraction. Extraction of cataract or the crystalline lens is the definitive treatment for almost all forms of lens-induced glaucomas. And in phacolytic glaucoma, the anterior chamber requires a thorough irrigation to remove all dispersed lens matter. Lens particle glaucoma occurs following disruption of the anterior capsule, either following cataract extraction or following penetrating trauma injuring the crystalline lens. Lens matter gains access to the anterior chamber and obstructs the trabecular meshwork. In lens particle glaucoma, the raised intraocular pressure occurs shortly after the initiating event. On examination, we'll find fluff-tough cortical material in the anterior chamber as shown here in this photograph. Intraocular pressure is elevated and there can be microcystic corneal edema. Moderate anterior chamber reaction can be found. Later, posterior and peripheral anterior synechia may develop. Though inflammatory reaction is present in lens particle glaucoma, it is not the major component of the disease. Like phacoantigenic uveitis, where inflammation is the major component of the pathology. Treatment of lens particle glaucoma is reduction of intraocular pressure and control of inflammation with steroids and mydriatics, followed by removal of the retained lens material in the anterior segment, and also extraction of the cataract in the post-traumatic scenario. Phacoantigenic uveitis is a rare entity and, as we have mentioned, is primarily inflammatory and was previously called phacoanaphylactic uveitis. It is basically a granulomatous inflammation due to the patient becoming sensitized to his own lens protein after surgery or trauma. And histopathologically, we will find granulomatous inflammation surrounding nidus of lens material. This entity is particularly likely to occur with retained nuclear fragment in the vitreous cavity following cataract surgery or trauma, and it takes several weeks to months following the initiating event for the inflammation to be clinically detectable. And this interval differentiates phacoantigenic uveitis from lens particle glaucoma, in which raised intraocular pressure occurs soon after the initiating event. The initiating event is the surgery or trauma disrupting the anterior capsule, being the same in these two entities. Signs of phacoantigenic uveitis includes granulomatous keratic precipitates, as seen here in this photograph, as well as deposits of these inflammatory cells on the anterior lens surface. There will be a moderate anterior chamber reaction, and a low-grade vitritis can also be present. Posterior and peripheral anterior synechia develop later, and as we have mentioned, raised intraocular pressure and glaucoma occur only in some patients with phacoantigenic uveitis, and a similar inflammation may occur in the fellow eye when it subsequently undergoes cataract surgery. Treatment of phacoantigenic uveitis is control of inflammation and intraocular pressure, followed by removal of the residual lens material as well as the cataract in the post-traumatic scenario. Other form of secondary open-angle glaucoma which we will discuss in this session is raised intraocular pressure secondary to elevated episcleral venous pressure. And when episcleral venous pressure increases, the intraocular pressure increases according to the Goldman equation, which we have discussed in a previous session. The normal episcleral venous pressure is 6 to 9 millimeters of mercury. And as we shall be discussing, some of the causative factors of raised episcleral venous pressure can be associated with significant risk of systemic morbidity and even mortality, and this is important to remember. Causes of raised episcleral venous pressure can be grouped into three: idiopathic venous obstruction and arteriovenous anomalies. Idiopathic elevated episcleral venous pressure is the most common and is typically found in elderly patients and is usually unilateral and tends to affect the right eye. Raised episcleral venous pressure secondary to obstruction of venous drainage can be due to retrobulbar tumor, thyroid orbitopathy, cavernous sinus thrombosis, which is secondary to infections of the face, nose, and middle ear, and superior vena cava syndrome, which is most commonly due to bronchogenic carcinoma. Raised episcleral venous pressure due to vascular anomalies can be due to arteriovenous fistula, either carotid cavernous fistula or dural fistula, orbital varices, and Sturge-Weber syndrome. Other mechanisms causing raised intraocular pressure can also be present, such as reduced trabecular outflow facility, neovascularization due to anterior segment or retinal ischemia, and acute angle closure due to congestion of the ciliary body. Symptoms of raised episcleral venous pressure is a chronic red eye without any symptoms of ocular discomfort, discharge, or itching. So the patient has a red eye without any other ocular surface symptoms, and the patient can give a history of head trauma directing the etiology towards a carotid cavernous fistula. The typical sign of raised episcleral venous pressure is dilated and tortuous episcleral veins, but there is lack of congestion of the conjunctiva in between these dilated and tortuous vessels. Blood in the Schlemm's canal can be detected, but this is an inconsistent feature and can be present in normal eyes and can be difficult to detect in eyes with significant pigmentation of the trabecular meshwork. Intraocular pressure will be raised, and in some patients will find intraocular signs of venous congestion and neovascularization secondary to ischemia. And clinical signs of the etiologic factor causing the raised episcleral venous pressure can also be found. The episcleral venous pressure can be measured, but the measurement techniques are mostly academic and research oriented, and we will not be discussing them here. Angiography, either magnetic resonance or conventional, is important to rule out serious causes of raised episcleral venous pressure when they are suspected. Treatment of raised episcleral venous pressure is treatment of the cause of the raised episcleral venous pressure and lowering of the intraocular pressure. Lowering of the intraocular pressure can be attempted with aqueous suppressants, and filtering surgery will be required when aqueous suppressants fail to lower the intraocular pressure effectively. Laser trabeculoplasty is not effective to lower the intraocular pressure when the intraocular pressure is increased due to raised episcleral venous pressure. And it is important to remember that filtering surgery in an eye with raised episcleral venous pressure is associated with an increased risk of choroidal effusion and or hemorrhage. And so prophylactic sclerotomies are recommended intraoperatively when filtering surgery is performed so as to allow escape of the fluid or blood if choroidal effusion or hemorrhage occurs intraoperatively. But these interventions cannot lower the intraocular pressure below the episcleral venous pressure as per Goldmann equation. So when the episcleral venous pressure is significantly elevated, treating the cause of the episcleral venous pressure is important to lower the intraocular pressure effectively so as to prevent glaucoma progression. Differential diagnosis of red eye and dilated vessels of raised episcleral venous pressure include conjunctival infections and allergies, scleritis and episcleritis, scleral thinning, intraocular tumors, and ataxia telangiectasia. In these three entities, we will find diffuse congestion of the conjunctiva, episclera, or the sclera, in addition to dilatation of the blood vessels of these layers. So to recap the salient points, lens-induced glaucoma can be either of open angle or angle closure mechanism. Phacolytic lens particle and phacoanaphylactic glaucomas are open angle in nature. Phacolytic glaucoma occurs in an elderly patient with a pre-existent mature or hypermature cataract but with an intact anterior capsule. There is leakage of high molecular weight soluble lens protein through this intact anterior capsule, and these proteins and macrophages which engulf these leaked proteins block the trabecular meshwork. Phacolytic glaucoma has a sudden onset with pain, redness, and further blurring of vision in an elderly patient who already has a history of poor vision for a significant duration due to the cataract. On examination, large particles, some of which are iridescent, can be detected in the anterior chamber. Keratic precipitates are absent in phacolytic glaucoma, and treatment of phacolytic glaucoma is control of intraocular pressure followed by extraction of the cataract. Lens particle and phacoantigenic glaucoma occur following disruption of the anterior capsule, either following surgery or following trauma. In lens particle glaucoma, raised intraocular pressure usually occurs soon after the disruption of the anterior capsule. Phacoanaphylactic uveitis or glaucoma has an onset several weeks to months later. In lens particle glaucoma, fluffy cortical material is present in the anterior chamber which obstruct the trabecular meshwork, and treatment includes control of intraocular pressure and inflammation followed by removal of the lens matter, cataract extraction, and thorough irrigation of the anterior chamber. Phacoantigenic uveitis or glaucoma is primarily an inflammatory entity which may or may not have associated raised intraocular pressure. In phacoantigenic uveitis, granulomatous inflammation occurs in response to the lens matter exposed following disruption of the anterior lens capsule. Treatment includes control of the intraocular pressure and inflammation followed by removal of the lens matter. Raised episcleral venous pressure can be an idiopathic entity or can occur due to venous obstruction or arteriovenous anomalies. Patient complains of red eye but without discomfort or discharge. On examination, dilated and tortuous episcleral veins are present and blood may be detected in the Schlemm's canal. Treatment involves correction of the underlying cause of episcleral venous pressure if possible, aqueous suppressants, and filtering surgery. IOP cannot be lowered below the episcleral venous pressure according to the Goldmann equation, and filtering surgery has the risk of choroidal effusion and hemorrhage. Laser trabeculoplasty has not been found to be effective to lower intraocular pressure in patients with raised episcleral venous pressure. Thank you for listening.